We're the palliative medicine and oncology teams from Denver Health, and we're here to talk today about how disciplines work together to offer whole patient care to those diagnosed with cancer. Thanks for joining us. I'm going to let our team introduce themselves as we go along, because part of our presentation is going to be tell you what our roles are. So first, we're going to cover what do we each do separately. We'll talk about common misconceptions for each of our fields. And then we'll work through a patient case to show how do we fit together and then we'll take your questions.
So should I talk?
That's you, Mike.
Okay, so I do the hematology oncology. It's a team of doctors and nurses who work in the immediate treatment area, and I'm kind of representing them today. And we see the patients first, and then we interact with the families and the consulting physicians who have asked the questions, and try to put things into a workable format in a fairly short time frame if we can. And then the whole game starts, and you're all part of it. True. There's no myth here, of course. This is our main job, is to give chemotherapy and then give it again. But of course, you all know that's not true, so we just put that out there.
And I'm Dr. Kelly Ferraro. I'm a palliative medicine physician at Denver Health. So palliative medicine is what I like to call the best possible medicine. We are specialized medical care focused on people living with serious progressive illness. And I love it because I get to focus on the patient as a person. I focus on what is their stress of their symptom burden. What's their changing role in life as they navigate illness. I try and make sure that we're really giving customized medicine. One of the oncologists on our team said, you know, people now think customized oncology is giving gene-directed therapy. That's true, but also customized medicine is knowing whether or not your patient has a car to be able to get to their appointments or they're taking the bus. Palliative medicine is appropriate at any stage of illness and at any age, and it can be provided alongside curative treatment, which is really important for us. So these are two different models of care. For palliative medicine, we have an interdisciplinary team focus. We're looking at understanding the patient's illness, understanding their treatment options, and then having true shared decision-making where the patient shares with you what is important to them in their life, and you help match what medical treatments are available to meet those goals. We also focus on a shared support of patients and their caregivers. So looking at a family model, looking at a societal model and saying who's important in their life and who's also dealing from this trauma. So you can see here these two different stages. So you have diagnosis of a life-limiting illness, and then over time, we either are seeking life-prolonging curative treatment, and somebody transitions from that into fully comfort-focused treatment and seeks hospice care and then death. But with us, with palliative medicine, we're really thinking about they have a diagnosis of a life-limiting disease, and we watch as these curative, life-prolonging treatments decrease in nature as symptom management or palliative management increases. Then over time, they may change to fully not having any life-prolonging curative treatment and switching over to their Medicare hospice benefit, at which point death would occur and family bereavement would be assisted. So I think it's important to realize when we think about palliative treatments, many of the things that are offered are not curative in medicine. Treatments for COPD slow the disease, but they don't cure COPD. Many cancer treatments at this point are very, very effective at slowing cancer treatment, but are not a cure, do not fully eliminate the cancer. Heart disease treatments, many of your patients, almost all of them, are on some type of palliative treatment already at this point. For us, common myths that we hear are that we're the people who tell you to stop the chemo. One of the things that I really actually love is helping people, if it's within their goals, to get more treatment, right? To feel better during that treatment. And so they can tolerate the stronger chemo. We have a patient right now who's on a curative path for cancer treatment, but is having a lot of side effects, and helping her navigate that so that she can get the full treatment and the best possible chances of cure is something that's really important to me in my practice. And then also myth busting that you don't live as long, it's quote, if you go on palliative care. We hear go on palliative a lot. Again, I would reiterate that many patients are already on palliative treatments. There's no really such thing as going on palliative. But palliative medicine really exploded over the past decade because of the studies that show that our involvement not only helps improve quality of life, we actually help improve length of life as well.
Hello, my name is Brandon McCarthy, and I am a registered nurse in the Infusion Center at Denver Health Hospital. So just to provide a little overview of what the Infusion Center does and what nursing looks like, an Infusion Center is an outpatient clinic that is certified to administer infusion-based therapies. So after a patient is diagnosed with oncology and then sees a physician like Dr. McLaughlin, the medications that are deemed necessary will be ordered. And then if the patient doesn't require inpatient status, they are able to come and receive their treatments in the infusion center, which allows them to then be home in the evening to have dinner with their families and to sleep in their own beds and to maintain their quality of life. But as many of us know, most oncology treatments are hazardous medications. And so the administration of these medications does require that a chemotherapy and biotherapy certified nurse administers said medications. And this is where the Infusion Center has really become quite popular in recent years. In fact, as of 2020, each year now, 650,000 oncology patients receive their chemotherapy in infusion centers on an outpatient basis, as opposed to being made inpatient or receiving it in a physician's office or private practice. And I couldn't find a lot of current data, but there was a study conducted that showed between 2004 and 2014, the use of infusion centers increased from 6 to 43%. So you can imagine that in the 7 years since then, how much more it's increased. And while I couldn't find any concrete data, I did recently read an article that suggests that infusion center use has likely increased up into the 80th percentile. And this is because it allows patients to maintain their quality of life. It's a very efficient way of administering these medications to a lot of patients at one time. And it's also more cost effective in treating these patients than making them inpatient and having them stay in the hospital. So specifically on a day-to-day basis, nursing in the infusion center is quite honestly the culmination of a lot of moving parts. Obviously, they get seen in the clinic first, and this is where the ball kind of starts rolling in terms of their medicines being ordered. And so they come and they see us, and as you can imagine, some of these therapies take all day. And so they really spend quite a lot of time with us in the infusion center, and we get to know them and they begin to open up to us. And so while they're getting their chemo, they might, say to me that they're having trouble getting into their infusions, or they're not feeling good and they can't eat. And so when these things pop up, not only are we just giving their chemotherapy, but we're also reaching out to psychologists and registered dietitians about not only giving them chemotherapy, but treating them holistically in a truly collaborative nature. So not only are we dealing with these sorts of things, but while these are happening, I'm also on the phone with the physician discussing critical lab values, or I'm talking with the blood bank about getting my patient their 2 units of blood because they tested positive for antibodies, and now the blood has to be sent from Bonfils. And so it truly becomes an interdisciplinary collaborative approach to taking care of these patients in the infusion center. And at the tail end of 2020, I conducted a survey and found that while oncology and hematology patients account for the majority of the patients we see, I was surprised to find that it's actually only about 57% of our total patient volume. So not only are we dealing with the oncology clinic, but I'm also talking with rheumatology about the rheumatoid arthritis patients, and GI about their Crohn's and colitis patients, and the MS patients from neuro. So, I mean, it's quite honestly a holistic, collaborative, and interdisciplinary approach to providing care for these patients in a holistic manner. As far as Mythbusters are concerned, I'm not sure that there's really a myth or stigma concerning specifically the Infusion Center. What we do get a lot are questions such as, when's my hair gonna fall out? What do I do if I'm gonna get sick? And how bad is this gonna hurt? Most patients, as you can imagine, are pretty nervous their first day coming into the Infusion Center. And what's fun is kind of debunking these questions. While this might be the experience with some patients, most patients, with the advancement of our treatments, specifically in regard to antiemetics and pre-medicating before they begin, is that they realize that their treatment, their time in the infusion center is actually not going to be awful. And we find that as they come their second, third, fourth time, many patients have expressed that they start to look forward to coming. Not only are they receiving their treatment, but it's the one time where they don't have to worry about anything else. They get a warm blanket, they get a chair, TV, and snacks, and I get to handle everything else while they just get to relax. And it's really neat to watch patients kind of on that journey. So that's what Infusion Center looks like, and I believe Catherine is going to discuss the clinic side of nursing next.
My role in clinic is very interesting, especially in the context of interdisciplinary team, because not only do I do nursing on the oncology side, but I also am a nurse on the palliative care team. So that means I am in the middle of these two different modes of care, and I freely flow between the two of them, sometimes in the same conversation with the same patient. So it's incredibly nice because not only is there sort of an understanding right off with the patient of, okay, you have cancer, here's the treatment you're going to get, here's what that might mean in terms of side effects, but then also being able to do an immediate handoff to, and we have a palliative care team here that in the event these side effects become very debilitating, we're able to support you through that. And beyond just the side effects, our clinic is also prepared to help you psychologically with social work support, grants, etc. So it's very nice that I feel very comprehensive in terms of the conversations that I'm able to have with patients. So that's what I mean about freely flowing between both mediums of care. Real-time perspective on the shifting needs of patients. So what I mean by that is part of this, a big piece of clinic nursing is that I am often the first person a patient is going to be in contact with before or in between provider visits. So that means with some patients, I may talk to them daily at times or at least once a week. And I hear very quickly or rapidly how things may be getting harder for the patient. And then from there, it's a judgment call on, okay, do I reach out to the oncology provider because this sounds like it's something that's very much related to treatment and we might want to address the treatment for, or is this something where the patient needs just an extra level of support to help them with whatever distress they're currently experiencing? And then again, the advantage of being in this position, I feel, is that because I do have interaction directly and often with both the providers from the oncology and the palliative care modes of patient care, I have expertise across so many backgrounds to draw from in order to find the best solution for the patient. So I love this role because it allows me flexibility, and there's creativity and ultimately a lot of resource to just get down to what is the right thing to do for the patient at a given moment. And then on the next slide, I tried to illustrate this by, okay, there I am in purple RN, right in the middle of these two teams that have a lot of overlapping expertise. So as I've mentioned, there's a provider on both sides of this model, but we also have a social worker in each modality. So a social worker who is more in tune with cancer care specifically, and is very helpful in terms of being a resource I can hand a patient off to for financial support, getting things they need in their home, etc. But then I also have this on the palliative care side. And there are some distinct differences in what our social workers in clinic handle and who covers what. So again, depending on where that patient is at and what their need is, I just need to navigate them to the right social worker to help them with their need. Then we have MAs, same MAs on both teams, but obviously a great resource for fielding potential patient questions and other issues that come up. Now, oncology, infusion is pretty specialized with oncology. And obviously, Brandon did a great job of covering that. Really, my role with infusion is occasionally taking a critical lab value from them. But because a large part of my responsibility on the oncology side is educating the patient about what their chemotherapy regimen is going to be, I use that teaching opportunity to also talk to them about what their day in infusion is going to look like. So in addition to getting these drugs, I try and reemphasize, oh, here's how long you're going to spend. Here's what they're going to do. They're going to take your blood. They're going to look at your blood before they make an ultimate decision to give you infusion. And I reemphasize that they're going to get medications before infusion to help them control any nausea they might have. So trying to paint a picture for what the oncology side of things is going to look like for them once they start actively receiving treatment. And then in terms of other specialties, both for oncology patients and for the palliative patients, I'm always happy to recommend Allison's services to them to help bolster them psychologically, and then also our chaplain. And then finally, our myth is it's all about giving chemotherapy and watching people die. This is absolutely not true. It is so much more than giving people medicine. It's giving them the medicine they need to buy them the time they want or to help cure them, and helping them through that psychologically, physically, emotionally, every step of that way. It's so much more than watching people die. I think that's a very common misconception about working in oncology nursing. Thank you.
Thanks to both of you. And Dr. Allison Lieberman is going to speak in a minute. We have an audience question maybe for Brandon and Catherine. They're wondering if and when we'll ever be able to send the newly certified onc RNs to the Infusion Center. The experience really is invaluable. Brandon, would you like to take a shot at that?
Sure. I guess my first question would be, would this be like a shadowing experience or to actually work?
I think how the question is framed, it looks like shadowing.
Yeah, I mean, I think that would certainly be an option. Obviously, that would be something to take up with the leadership team. But I know that we do a lot of nurses who are getting certified in chemotherapy and biotherapy who work inpatient They do come into the infusion center so that they can get signed off on their chemotherapy hangs, just due to the volume of chemotherapy that we do administer. So it's absolutely something that I think is possible. Yeah, I would just get in contact with the leadership team, and that is easily something that can be accommodated.
At Denver Health, is there a specific person for those at Denver Health to contact?
At Denver Health specifically, the person would be Casey Grant. She is the manager of the Oncology Hematology Outpatient Clinic.
She's awesome. Okay. And now we're going to ask Dr. Lieberman to tell us about the psychosocial.
Thanks. So I'm Allison Lieberman. I'm a clinical psychologist and I specialize in integrated behavioral health. So I get to be a part of our oncology and palliative care teams, which is really a wonderful experience and something I really enjoy as part of my job. So in this role, I'm addressing the different psychological, behavioral, social, and emotional issues that arise for cancer patients and their families and loved ones. You know, the individual reaction that people have, they can have distress or not have distress, you know, at different points in their cancer journey or, you know, more chronic disease processes. They, you know, they may struggle at the initial diagnosis. They might struggle when they're facing different types of treatment. They might have reactions to going into remission or dealing with recurrence, dealing with end of life issues, or a lot of folks that I see are struggling what I call, you know, when the dust settles. So now they've completed treatment and then the emotions kind of rise to the surface. And so people have a hard time understanding why that's stressful because, you know, now they're done with treatment and why are they struggling at this point? So I do a lot of normalizing of people's responses because it is very individual. And there's a lot of things that can influence how people respond to the stressors in their lives. Obviously, you know, dealing with cancer and dealing with chronic illness and side effects can bring up a lot of different things. And so looking at kind of what their baseline resilience is, looking what their support system is, what their resources are. You know, when we think about our Denver Health patients, they're generally very under-resourced patients. And so we're exploring those areas and how that might play into their reaction to different diagnoses and treatments. Looking at the type of cancer they have, obviously. And it's interesting to me because, you know, patients, we assume that, you know, if they are diagnosed with a more incurable illness or more advanced disease, that they might have a stronger reaction to things. And the reality is it's very individual. So we've had folks that have a very curable illness that have a really intense reaction. And we've had folks that have had, you know, very advanced and terminal diagnoses that have been, you know, at a place of peace and acceptance. So as I, you know, I can't reiterate, it's a very individual reaction that we need to be aware of. So there's a lot of other factors that come into play, including family and loved ones and partners and how they react to a patient's illness. You know, patients will sometimes put aside their own reactions to things because they want to be strong for people that they care about and they don't want them to worry. So they may or may not share relevant information. They may or may not elicit support, you know, and they may just kind of put on the brave face in order to, you know, function in their role. So yeah, I help in a lot of different areas, and also, I mentioned on here, health behavior change. So looking at some of the other factors that could potentially impact treatment, whether it's weight, smoking, alcohol, substances, there's a lot of ways in which I can be useful in helping patients navigate this treatment process. And yeah, so the Mythbuster, looking at my role, I'm an integrated care psychologist, so I'm used to explaining kind of what I do, because why is there a psychologist in the oncology clinic? Why did they send the shrink in? They must think I'm crazy. And so this is a very comfortable subject for me. I often am telling people what I do and how I do it. We have, oncology fellows and different learners that come through our clinics. And so it's often the case that I'm exploring my role and sharing with them all of these different realms in which I work. Now, there's also, one thing I forgot to mention, explaining my role too, is the team dynamics and how different providers interact with different patients, and the emotions that are elicited by patients that we see. And sometimes, we're kind of supporting one another, we're processing difficult cases, we're recognizing our own reactions and responses to patients, and why do some patients, make us frustrated, and why do other ones kind of pull at our heartstrings? So we support each other, and we're all kind of working together to provide the best care for our patients. But getting back to my Mythbuster, I really try to normalize that. I try to meet with as many patients that are coming through our clinic as possible. And, Dr. McLaughlin will tell you, he'll send me in and say, Allison, go find out how they're really doing. If he's concerned that, they're telling him one thing and there might be something else going on beneath the surface. So, I really normalize that cancer can evoke stress, on a variety of levels, and life doesn't stop just because, we're dealing with an illness. There's all these other factors that come into play, family problems, mental health issues, work, financial stress, all these different things that may be going on prior to any diagnosis or treatment that we're facing. So we have to make sure that we're looking at this whole picture and addressing things as they come up. I talk to patients a lot about coping, and my job being helping them just navigate this process and cope with whatever it is that comes up for them. And I try to really take a strengths-based approach and find out what it is that helps them cope with stressful situations in general. Have they dealt with other stressful times in their lives? Have they dealt with other medical illnesses? A lot of our patients have been through trauma. And so looking at how that's impacted them and what coping strategies they developed, whether they're positive or negative, and exploring how this can relate to what they're going through here. But really, kind of looking at this whole picture of, working with the patient, working with the team, really being kind of a bridge to helping patients advocate for themselves, communicate effectively, making sure that their voice is heard and that this feels like a collaborative process.
I know you've been invaluable for our patients and I will say for myself many times to reflect. So we have another question from the audience, and Dr. McLaughlin, I was wondering if you'd like to give first thoughts, and then we'd open it up to the team on this one. What are your thoughts on providing oncology care, including infusions, at the patient's home, rather than managing patients to come into the infusion center?
I guess obviously it depends on all kinds of things. I mean, first off, would we get paid? Obviously. And then all the safety issues that would be part of the deal. We have a lot of rules, whether or not they're valid anymore in terms of how we give treatments. Some of the dangerous drugs are no longer used. But I mean, some places in Texas, I know people were given their chemotherapy. They were 2 or 3 hours from the city. I was reading about this a few years ago. And they had, they had a local nurse who travel with them to the main clinics, and then at MD, I think it was. And then at the hometown, they would come over to the house. It would be mailed to their to the nurse pharmacist there, pick it up, dilute it, and take it over for their, it was ABVD in that case. But I mean, we're moving in that direction with our choice of drugs already. What happens next, of course, will be, you know, somewhat transitional in terms of how we handle some of these new medications.
Brandon, do you have thoughts on that from the infusion center side?
Yeah, like Dr. McLaughlin touched on, I was just thinking about the safety to the patient involved in administering these medications, particularly what type of access do they have? Is it a vesicant? These sorts of things. And, you know, basically, again, as Dr. McLaughlin touched on, but when it comes to reimbursement and you're basically paying one nurse X amount of hours to be with one patient, whereas in the infusion center, one nurse is with 3 to 4 patients. So from an insurance and billing standpoint, it doesn't make a tremendous amount of sense. Obviously, I think everyone would prefer to get it at home. I don't know what that would look like logistically.
Yeah, I think on a palliative medicine side, we're always looking at ways to integrate in clinics. And so, for instance, Brandon and I had a shared patient where the chaplain on our team and I went over and saw a patient as she was getting her infusion in the infusion center. You know, we have a lot less safety, clearly, issues. What I will say is we're trying to do more telehealth. And we were thinking about that pre-COVID, but luckily kind of got the boost with that. It is hard from my standpoint for patients to understand that pain is a physical exam as a component, you know, evaluating their symptoms. There's a physical functional component. Often a key portion of my exam is actually watching how do they walk back to the room when they're sitting down. I see Dr. Lieberman nodding as well, right? To know what's a psychosocial component, you know, what's a psychological component of their pain. That's real pain, but it may not be pain that needs pain meds or opioids. It may be pain that needs to see a chaplain, maybe pain that needs to see a psychologist. And so it's difficult for patients once we switch to that model for telemedicine. Some of them then are, well, why do I need to come in? And I think navigating that, it's not a one size fits all. I do think many clinics at this point are working on having some type of you see the neurologist, you see the physical therapist, you see a chaplain, you see a nutritionist in an ALS clinic, right? And so I think that the whole system is moving to that in general, is at least an integrated clinic where it's one large lump. Most patients like that, some patients don't. No. Any other thoughts from the team?
Okay.
So we're going to talk about a patient case. This is a patient that we all shared that we found to be impactful and hopefully gives an example of true whole person care. I'll ask Dr. McLaughlin to kind of start with the oncology piece.
Well, I think I'm unmuted here. Am I unmuted?
Yes.
Okay, good. Well, I mean, I guess we're going to talk about this particular case, which has, of course, all kinds of tentacles to it. This was a male, 11-year-old with responsibility for 4 children because his wife was a bit of a druggie and she was off in the woods somewhere. And the children were between 4 and 15 or so, and they really depended on him. There was no big family support. And he came in with his own active disease with, extensive involvement of his pelvis with rectal cancer and bladder symptoms and all kinds of pain and bleeding and disability. But tried to minimize his functional capacity for all kinds of reasons. He wasn't very verbal, but I think mostly because he feared having the children taken away. And it was kind of one of the troublesome cases right from the start, because you knew the moment you saw him and reviewed the films and the case history that he was going to die. It was a matter of, perhaps not, and that sort of thing, but it was probably inevitable. And it was going to be on the margin if we had any survival advantage at all in terms of intervention with therapy. So it was kind of a bit of a foot race to the cliff. And it was clear that he was not going to identify or accept, issues that involve childcare and his own care without a lot of coercion and sort of pressure from everybody involved. And like I say, one of the unfortunate things was he was a nice guy. So you really couldn't get mad at him and kind of harass him in the way you'd like to. You had to kind of do it gently. The fellow I had at the point, had decided on the afternoon we first saw this man to admit him to the hospital and put him on a port and give him chemotherapy. And I'd asked him, I said, well, that's all very good, but he's got a 3-year-old laying on the floor in there and he has a 12-year-old looking out the window. We just can't do this. And I remember the fellow was mad because he didn't realize that we're supposed to look after the family as well as just pour drugs into people. And he wasn't our best fellow, let's put it that way. And we had to redirect everything at that point in terms of how we're going to handle this man and get a lot of other people involved, not just on the medical side with urology and surgery, but, from the family issues and from his own personal issues, there was obviously problems that were going to come our way. And we got people involved right from the start. My feeling was at the point that I first saw this man that he needed, frankly, he needed female support. He just didn't need me, going around writing orders. He needed to have a perspective of childcare and his own lack of recognition of looking for help. He fundamentally needed that, support, maybe not intellectually, but he did need it to be carried out. So we got people involved right away in terms of those issues. And I think that was fundamental to how the next year and a half turned out.
Brendan, would you like to talk about your experience in the Infusion Center?
Sure. So when he presented to the Infusion Center, consistent with everything Mike just said, he's a lovely man. But he would show up late or occasionally not at all. But when he did show up, he would often be noticeably agitated and stressed out. And again, he didn't open up easily, but once you got to know him, he would start to talk about just the difficulties he was experiencing in his personal life. And I mean, not only did he not feel good from having cancer and having to deal with his treatment, but also he was having a lot of home issues, financially, childcare, and the big one for us was transportation, getting to and from his home to the infusion center to receive his treatments. And so, that's kind of what he looked like as far as coming into the infusion center all the time. And so we would just try to stay open in communication with him in terms of what's going on and support him however we can. And so then I would touch base with the nurses in the clinic, specifically Catherine, and because they have a lot more resources available to them to treating the patient as a whole.
So I'll say that our team actually met this patient inpatient, and I met him there. I think he had been referred to us several times, but because of these issues of no-shows, and it was really pre-telehealth, he had not shown up. And I came in, he was in the hospital for pain from his cancer, and he was very, very angry. And he said, "Get that team, I'm leaving." He said, "I'm out of here." And he wanted to leave AMA. And at the same time as I walked out to try and call the main team and say, what, this wasn't part of the consult, what's happened since? The oncology fellow and attending walked up, and we started to learn what was happening. And as I sat with him and validated how frustrated he was, because he had been in the hospital for a day, and while everyone was talking behind the scenes, we know that for patients, it often feels like, quote, nothing's happening. Lots was happening. We know that on the medical side, but he felt like nothing was happening. And I learned that his kids were at home texting, saying that they were going to not have food after a day. And so he was choosing between staying in the hospital and getting pain control and trying to make sure, and he was trying to arrange that his landlord would bring them food. It was the July 4th weekend. But she wasn't sure if she could. or if he could stay and kind of get some more scans and get some more plans going. So it was a really tough place because initially, you know, he presented as being very, very mad. I agree with everybody here as, you know, my time with him progressed, taking care of him. He's always a very nice man. But I think we see that those patients who present as angry are often behind that scared, right? And so I actually worked with the oncology team and brought that worry to them and said, so we said, what's the trade-off? He gets the scan here and he stays overnight. We get the scan, but as Brandon had mentioned, transportation had been a huge issue and he hadn't shown up for multiple outpatient scans. And so we felt like getting the scan there, and we arranged for him to get food delivered to his home for the kids who were old enough. There was someone old enough there to take care of the kids. There was no longer a 3-year-old involved. But so they were supervised and they had food, and then he would stay for the scan and he would go home the next day. And so maybe and we referred him to our clinic. Once he knew us, he decided we were useful. And Catherine, maybe you can speak about that experience.
Interactions with a lot of my interactions with this patient were more on the palliative side, in terms, like, I would speak to him more specifically when he would call in needing more pain medications. And that's always just a really great opportunity to check in with someone and see how they're feeling in the course of their treatment. Obviously not just the pain, but to have a few minutes to listen to his stresses in relation to his kids or whatever else was going on in his life. I will also say that tracking along with everyone else who's spoken regarding this patient is he was a little hard to track down at times. So it was a lot of my job was just making sure that I could find him and check in and continue to offer him support. I mean, and that was, you know, reaching out across a number of people he had listed as contacts. So, yeah, really sad, but I could tell just every time we talked to him, he felt supported by us and that he felt he trusted the care he was getting.
And then he was one of those patients that told me I'm not crazy the first couple times we tried to send him to Dr. Lieberman. And maybe she can speak to how she helped support him and acknowledged he was not crazy.
So this was a really interesting case for me because I got to know him very well in spite of not seeing him. He was referred to me, and I heard many, many things from many team members, including our social worker, who tried so many different ways to support this patient. And, you know, as everyone mentioned, this was a likable person who had a lot of barriers to getting the care and support that he needed. So here you've got a whole team of people that are trying to help this patient and even trying to refer him to me. And yet he no-showed. I mean, I was looking back. So he was initially referred to me in 2019. I did not see him. I've never met him in person, quite honestly. But thanks to COVID-19 and the ability to provide telehealth, he answered the phone when he was referred to me for a telehealth visit. And so I did have 2 real psychotherapy visits with him over the phone, which was fantastic. And he actually was really grateful for the care and really expressed a lot about, you know, what this whole process has been like for him. You know, in addition to, you know, the anger that he had been experiencing, he had a lot of sadness. He realized that his frustration level was really high, and that he had a lot of worry and preoccupation about, you know, what would happen to his children after he passed away. He had paranoia also that he was pretty well aware of, that, you know, he was afraid that people were out to get him at times, that his depression would get so bad. that he felt, paranoid. And he also had kind of this fear of impending doom, like something horrible is going to happen, and he would get panic attacks, just kind of getting himself worked up about things. So, it was wonderful, and that I was able to have these visits with him. But I think, supporting the team and just being able to talk about all of the ways in which everyone, tried to help and was making all these efforts, including myself with the, having him set up with me for visits that he didn't show up to. So it was an interesting, challenging, and also gratifying case, I would say.
Yeah, I think from a personal standpoint, but a lot of what I heard on the team, and myself included, was that I felt a lot of distress around his care because we felt like we could really help him. And he would present in distress and then, kind of have this help seeking, but then disappear, or his phone would be turned off. And part of that, sometimes the phone would be turned back on, and we would say, he would actually say it had been cut off for finances. And sometimes he would just say, well, I wasn't feeling good. And you would think, but I could have helped you feel better if you just pick up, just pick up. And a lot of, for me as a mom, he was weighing on his kids. He would talk about that he was kind of using the older kids for support. And I tried to really lead him to support for the kids, to say, we have these resources for the kids. Let's make sure you're worried about them. There was this barrier there, but I really appreciate that. Dr. Lieberman, we have a question. And I thought maybe this could be for you. And then if anyone else has resources, do you help patients engage in outpatient therapy or counseling? And if so, do you have a referral list for the area?
Yes, and yeah. A lot of what I do is getting people connected with a different type of care. Because I'm integrated and I'm only with our team for part of my week, I'm a limited resource. And so I have to make sure, that people are using my resources appropriately, and also really assist them in getting connected to different types of care. There are some really great places in the community, including University of Denver has a Center for Oncology, Psychology Excellence, the acronym's COPE. They are a wonderful program that I often will refer to, and I have plenty of other resources depending on what the needs of the patient are, right? So if we're dealing with severe persistent mental illness, I'm going to try to get them connected with some of the community mental health centers. But if it's more cancer related, I have some resources in addition to COPE that I often will refer to.
I love that. It's not one size fits all. So for this patient, he had not presented for any infusions or cancer treatment for, 6 months to a year. Despite our biggest attempts, and things had really progressed. He was having worse pain. Actually, a couple of months ago, we helped him enroll with the supportive hospice, acknowledging that if at any point he changed his mind, but he just wasn't coming to things. The last I checked on him about a month ago, he told me that they had provided him with a huge amount of psychosocial support, right? And so that part that he wasn't presenting for, they brought to him. And because of that, he was getting kind of some extra services. I truly believe he'll actually be someone who lives longer with the supportive hospice, simply because he's somebody who was not coming for the cancer treatment that I do believe could have helped him. But since he'd chosen not to do that, he was missing all of these psychosocial support aspects. And for instance, hospice brought him a walker. They brought him a bed. They were helping move them into a new apartment. They were really going above and beyond, helping with his pain control, making sure that the kids had support and they were hooked up with the school social workers. And so he was an interesting case. He's not under our care anymore because he's with the hospice, but I think a tough case for all of us. Would anyone else like to add anything from our team?
I mean, just not that it's relevant to the overall picture, but just I remember specifically, we talked a lot about how he no-showed a lot, which he did. But what was interesting psychosocially about him was that he would frequently call us when he was supposed to be there and just say, "Hey, I'm so sorry, I'm not coming, but I feel bad. What can I do?" So that was just how he operated. So, yeah, it's nice that he's getting the help that he probably needs and wanted the whole time.
How did you feel when he would call and say like, but I don't feel good? Can I ask you that?
Sure. Well, it was emotional because, I mean, he frequently would call crying. And so I spent on multiple occasions a fair amount of time on the phone, just talking him through, whatever was going on. And I mean, every time I would encourage him to come in and get his treatments. But, I just a lot of positive reinforcement. I thought was good for him. But yeah, I mean, on my end, personally, it was difficult. I really thought he was a very, very sweet man, and I wanted him to thrive. And I know he had so much on his plate, and it was challenging.
Catherine, I know you took a lot of those calls too. Would you like to chime in?
Yeah, I think really just echoing what Brandon said. I think as a practitioner, so often we're filled with solutions for people. And we know, okay, but if you just do this thing, this is going to make such a difference for you. And unfortunately, this patient, especially as someone who really taught me, my solutions aren't always their solutions. And while I can promote what I think will help them, I mean, sometimes you just can't bring them to that place for whatever reason. And in his case, obviously, all these external factors just culminated in an inability. So I think at that point, it's just being friendly, kind of trying to hold him as much as possible verbally with words and, just kindness and, just learning to accept that we've all done what we could for him. And now how do we help him get to the next stage for someone else to help with what he needs right now?
Yeah, I really love your line that my solutions aren't necessarily his solutions. And I think that's something that we work on as a whole team being okay with, which is really hard to be okay with, to say like, we have a solution. And I think, he actually had a curable cancer at his initial presentation and then disappeared for a long time. And that was something really emotionally tough for us to see. So I hope that you can see that we all turn to each other to say, like, I know you're doing a good job. I know you're trying. Brandon, thank you for talking to him on the phone. Catherine, thank you, and all of us working together to say, we're in this together, but his solutions weren't our solutions. And, this was going to be his path. We have about 5 minutes left before we wrap up. And so I wanted to make sure we get to, there's 2 other questions. Do you send patients home with infusion pumps? Brandon or Dr. McLaughlin, would you guys like to address that?
Yeah.
Yeah, go ahead, Brandon. Sorry.
No, you're good. Yeah, depending on the regimen that the doctors, such as Dr. McLaughlin, ordered, a lot of regimens are usually the combination, at least from my standpoint, they'll come in and they get infusions in the infusion center, and then they'll go home with a pump as part of their overall treatment. So that's kind of the most common. The other thing we're seeing now is a lot of treatments that were formerly primarily inpatient. We're now seeing a transition to outpatient. The one that comes to mind is EPOC. And so we're doing a EPOC on an outpatient basis where they get a chemo pump and they just come into the infusion center daily, and we switch the pump out for another 24 hours, and they'll do that for a week, and that allows them to not be inpatient. So that's where I'm seeing it. Dr. McLaughlin, what are your thoughts on that?
Yeah, I totally agree, Brandon. But I guess I just want to say a couple more things about the palliative care, in terms of the interactions we take place quite apart from the pumps, is that, in terms of how the nursing and the medical and the psychological aspects of how we interact, there's no boundaries really that we kind of exist, behind when we interact on these patients' behalf. I really think that, talking about the patients, in an active sense in terms of the infusion experience and the at-home experience and the clinic experience are kind of integral to having a good palliative care program, that actually involves, the family and all the staff. When we send people to palliative care, for example, I even tell the MAs about this because, they're involved with the patient as well. They don't just sign them in and sign them out. And I guess that complexity of how this interaction takes place works because people accept, the fact that everybody interacts in a positive way for the patient's behalf. And, Kelly may want to speak to that as well, but I do think that's a message we should be very clear about with palliative care and oncology patients.
Yeah, I think, this for me is really about working together to meet the patient's goals, right? Is when we're all talking about this and finding out about them as a person, and then being able to actually engage in shared decision making because we know who they are as a person. Again, patients are being provided oncologic care based on genotypes, but it's also, if they can't get to the appointment, that's all moot. Or if they're too scared of the chemo infusion and they're not coming, it doesn't matter if we have a great immunotherapy, they don't show up. And so this is really about, for me, all working together from a standpoint of we're all here to try and help the patient. That's why I appreciate our team. We have just 2 more minutes. One more question that we have is, what local resources are available in the Denver area for patients with socioeconomic challenges? I can speak a little to that if anyone else would like to add in. One thing we often refer patients to is Project Angel Heart, which is in the Denver area. That's a Meals on Wheels program that is more designed to specific dietary needs. And then I would encourage you to talk to your social worker. There are lots of grants available for patients. It really just depends on, again, sometimes it's for a very specific cancer. Sometimes it's for very specific needs or demographics based on where they live. But we are always applying. I know our social worker works her tail off getting people resources. Does anyone else have resources they'd like to share?
I would say, depending on the agency as well, I know at Denver Health, we have a patient assistance fund that can often help patients, cover costs that aren't necessarily included under their insurance. So if there are tests, if there are medications, if there are equipment and things that are necessary, sometimes that's a resource that we utilize as well.
Great. Anyone else? We have about 1 minute. Well, thank you guys very much for coming. We're at the end of our presentation, and we'd like to thank you again for attending. We hope this has been helpful, and I can say I appreciate working as a team. Take care. Have a good morning.